Well, let's get Dr. James Burke from Lehigh Valley is going to talk to us about how we can inform cardiogenic shock management. How can we?
How can we? Good morning. I want to thank the Houston Shock Program for inviting me again. This is really a pleasure. It's also nice that I don't have to talk about pressure volume loops this year after Dr. Burkhoff has spoke about pressure volume loops. So my topic was Surviving Sepsis Campaign, how can we inform cardiogenic shock management? And I figured that should not be that easy or hard. I have no disclosures. One of my guilty pleasures is science fiction, and while I don't think Star Wars is the best example of that, I do think we can take some guidance from Master Yoda, and I will be perfectly honest that I have some biases. But as he said, many of the truths we cling to depend on our point of view, and I think that's true throughout all of the discussions we've been having in the last day and a half. The Surviving Sepsis Campaign, as many of you know, it's an international set of guidelines for the management of sepsis and septic shock. It provides guidance on the care of hospitalized adult patients with or at risk of sepsis. It was first published in 2004. It's had subsequent revisions in 2008, 12, 17, and most recently at the end of this last year. The stated goals are early identification and appropriate management in the initial hours after the development of sepsis to improve outcomes. And most of you probably who have rotated through the units have seen some of the sepsis bundles, whether you realized it or not. But they have sepsis bundles to help have performance improvement programs, and they include sepsis scoring, education, measurement of sepsis bundle performance or metrics, and patient outcomes. And it has been shown in some meta-analyses and in a couple of clinical trials that using the sepsis bundles does improve mortality in sepsis and septic shock. They do have sepsis screening tools, too, which, as you look through the new updated guidelines, they've simplified it, but there are the SIRS criteria, the Q-SOFA, the SOFA, the NEWS, and the MUSE. And I think many of us that use Epic, you may or may not know that the MUSE is actually built into your Epic system. And at our institution, they activated it, much to the chagrin of our pulmonary critical care people who kept getting phone calls for elevated MUSE scores. So in the most recent sepsis guidelines in 2021, they've updated many of their recommendations. And in those updated recommendations, of which there are over 20 either updated recommendations or statements of negativity for some of their prior ones, one was that they recommended using the SOFA score in your institution over MUSE or NEWS, pretty simple to do. And they also recommended, as we were discussed earlier, for patients with hypoperfusion or shock, they recommend 30 milliliters per kilogram of crystalloid given within the first 3 hours. So most of us in cardiology often have hypotensive patients that have come up from the ED and they've applied the sepsis bundle to them, again, much to our chagrin. They also recommended the use of dynamic measures to guide fluid resuscitation over physical examination or static parameters. Dynamic measures that they use are some interesting ones, and we can go into them a little bit later if we have time. And they suggest capillary refill as a way to guide resuscitation. So they really didn't put much emphasis in the new guidelines on measuring the CVP, obtaining a CVP. They do recommend looking at volume loading through some of those techniques, but the reality is there isn't a lot of hemodynamics in the sepsis bundle. They do recommend a mean arterial of 65, as was discussed before, as a pressure target. But cardiogenic shock is not septic shock, and as we look at these guidelines and how we can inform our care, I just put on both sides a few brief thoughts. Number one, sepsis and septic shock has a relatively common etiology, which is infection or inflammation. It has relatively low-tech initial therapies, IV fluids, IV antibiotics, IV pressors, and basic hemodynamic monitoring, blood pressure, heart rate, ECG. Those are available in all acute care hospitals. They do recommend, and I think this is important, education. By education, they mean emergency medicine, hospitalists, et cetera, in order to understand what these bundles are, and there's little further they can escalate to. Whereas on the other side, what we're dealing with is, as we've pointed out before, various etiologies and phenotypes. Initial therapies are variable. We have a lot of advanced therapies, which are not cheap, but we have that aren't available in all hospitals. I'm going to skip that. So there are a lot of variations, and the goal of bundles is to cut down on variations. And while we've seen this, and I think this is very helpful for escalation and de-escalation, how do we do that? And again, we were part of the Critical Care Cardiology Trials Network, and I think one of the things we found out is just the huge variability in use of all of our advanced therapies. So can we use these bundles or bundles of our own to help inform our therapy? We've seen that there's various use of these devices, but balloon pump is fairly consistent even in mixed shock or non-cardiogenic shock or acute MI shock. And if you look on this slide, as you go by the different levels of acuity, the utilization of these devices doesn't really change. We use the same amount of device, whether it's a low acuity, low SOFA, low IABP shock, or a high one. And again, when we look at our shock team paper, you can see that the utilization, whether you have a shock team or not, in all of these centers, which all were tertiary or quaternary care centers, is fairly different. When you have a shock team, you use less balloon pump, more Impella. And the key is, I think one of the issues is that only 42% in the original paper, 42% of the people who got advanced circulatory support, an Impella or ECMO, had a PA catheter placed. So when we talk about, as we look at how might we inform our care, I think when you look at some of these papers, we know that PACs have improved survival, and granted, this is from mostly registry studies. We know that there's a variable utilization of MCS in tertiary care and quaternary care centers with or without shock teams. And we see that they have, if you look at the left-hand side, fairly similar hemodynamic parameters. So, we aren't using our PA catheters when we have them to inform our care if we have this variability in use. So we have to figure out how else can we do that. And while I think we do have care pathways, and I think these are excellent pathways, and they have to be hemodynamically guided. So my bias, I'm an interventional cardiologist, and I view myself as being privileged to work in the most expensive critical care room in the hospital. I think, we have to basically inform ourselves and then the community on how we can best utilize these technologies. And while I agree with Ajay that not everybody needs a PA catheter, I think the problem is, a PA catheter is only $12 or $20, whereas a Impella device is $25,000. So it's hard for me to imagine somebody who gets an Impella and hasn't gotten a Swan. So I do think, too, we have levels of care. So, we have to educate our level 1 and level 2 hospitals in order to provide shock care, and we have to make those recommendations. And I'm hoping that out of this group, we can get some information. So PA catheter, I think, is important to guide hemodynamics. We do need some guidelines and metrics. We have to establish those, and I can't tell you what they should be. I have my own ideas. And I guess they froze. So my last slide, and I'll stop here, again, with Master Yoda. In a dark place we find ourselves, and a little more knowledge lights our way. So the surviving sepsis guidelines can only serve as a structure to maybe help us begin to educate and create a set of recommendations on how we can take our patients through this complicated pathway of shock. Thank you.
Thank you, Dr. Burke, and probably going to kick on the discussion. And I have one question regarding patient coming to the ER with in septic shock but have history of congestive heart failure, or patient having even undiagnosed heart failure and coming for the first time, how you are teaching your ER just to be regarding fluid management and to be careful in fluid management of those patients, and I would like also to ask how the audience is dealing with this issue.
Yeah, I'm not sure we can teach our ER physicians, I have to be frank, all that much at times. They exist in our institution and many, almost in a bubble of their own education and training. And I do think it's, we have a very busy STEMI alert program we do about 450 acute MI interventions a year. And we have a fairly set of simple guidelines on how to recognize a STEMI. And again, we still get called for ST depression in the middle of the night. So it's an indirect way of answering. I'm not sure we can teach them. I think it has to come. We can spend a lot of time trying to do that. It's difficult. And we all, I think, have seen basically people who have gotten 3 liters of fluid because, they're still hypotensive. And they come to the cath lab and their CVPs are 25.
So in STEMI, we have guidelines that say that if the patient can't get to an interventional lab in a reasonable period of time, we give them lytics.
Yes.
What about shock? The patient that comes into an outside hospital that doesn't have the advanced care that you talked about, what do we know about the time to transfer, and is it ever better to have them stay where they are?
I think for cardiogenic shock, the answer is no. I think for septic shock, the answer is yes. And I think that's, our goal, and one of my jobs at my institution is to try and improve both the education and recognition of those patients in those areas. And we've built our regional shock program on top of our STEMI alert program so that, we have patients, hospitals are already used to sending us their acute MIs. We just layer on a hypotensive shock patient into that system. It's not perfect, but it certainly is the beginning of how we can do that. And that's why I point out teaching our level 1 and level 2 hospitals, and the hospitals that have PCI but don't have, say, mechanical circulatory support, we make sure that we're the hub of the spoke, and I do expect they get a Swan if they get an Impella. That's an educational issue with our cardiologists there, but it is problematic at times. It's a system problem and logistics.
Go ahead.
How do you triage what patients should be coming in, especially nowadays where every hospital is at 100% occupancy? There's a lot of these cardiogenic shock patients who could be considered unsalvageable, or some that could be potentially managed. So how do you balance that if you're doing a hub and spoke model for shock?
Well, I think it is difficult. Even with COVID, we've had that capacity, but it's really only the cardiac arrest that we don't try and get over immediately. The rest of those patients, because it's also not fair to our system hospitals and our community hospitals that depend on us, they just don't have the capability of taking care of those patients. And we'd rather get them sooner rather than later. I'd rather get them sooner so that we take them right to the cath lab. As I said, we'll take them right to the cath lab. It's just difficult.
I wanted to relate to something you said earlier, which I think was really interesting. You said that some emergency physicians, and I think that's also true for other specialties, exist in their own bubble of education. And I think regarding that, we can really learn from the Surviving Sepsis campaign, because they manage, in the guideline, they obviously have a high degree of complexity, but they still manage to get the message out that you need to hit hard and early, antibiotics and fluids. And I think that's something we can learn from, because obviously here we are all into the topic of cardiogenic shock and all the details. But we maybe need to simplify for people who are not that much into it.
I think that's why I put the point about education. I don't think they're uneducable. I just think that we have to try and interface with them. I will say our problem is we have over, I think, 60 emergency medicine physicians in a very large ED. It's tough to educate and re-educate. It's one of those processes that is never ending, and I accept that as a reality, which is fine. It is hard to find the champion. I think the easiest way is to find a champion in the ED that will push this forward among his or her colleagues.
Okay.